Our next speaker probably needs no introduction. In fact, in our first meeting, he told me that he's actually been in the telehealth world really since before I was born. And I am no spring chicken, believe me. So he spent his professional career working with governments, educational institutions, and businesses to address the problems of cost, quality, and access to healthcare. Today he's going to discuss where we are today with telehealth and the future of the healthcare delivery system and the role and impact on the patient, the provider, and the payer. Please join me in welcoming the father of telemedicine and a founding member of the ATA to the stage, Dr. Jay Sanders. Thank you.
Well, you know, I'd like to begin with a huge thank you. Not simply from me, but from my professor of medicine, Dr. Ken Bird, who told me about his idea of telemedicine in 1967, when I was a third-year resident in medicine at the MGH, and I was actually running the emergency department a late summer day, standing out in front of the ER, waiting for the next usual Boston traffic accident victim to come wheeling in from EMS, when all of a sudden the ER doors opened wildly, and there standing in the door was my professor of medicine, Dr. Ken Bird, red-faced and sweating and looking upset, and I knew exactly why. Because Ken Bird, like many Harvard professors in those days, as a full professor, was making a grand total of $8,000 a year. And he was moonlighting, like every other Harvard professor, and he was moonlighting as the medical director at Logan Airport Medical Station. Those of you who have ever been to Boston before the 2 additional tunnels from the airport to the center of the city will know that it used to take a minimum of an hour each way to go from the airport to the MGH. And Ken had to do this every single day. And this particular summer day, while parked under the Charles River in the Sumner Tunnel, because that was the only tunnel. There was no Callahan Tunnel. There was no Ted Williams Tunnel. He got an idea. And as he came storming through the door, he saw me, and he came walking up to me, and he grabbed my arm, and he said, "Jay." And I said, "I know, Dr. Bird, I know you got caught in the traffic again." He said, "Yes." He said, "But I had this idea. What do you think about it?" He said, "What if I get 2 TV cameras?" Remember, this is 1967. What if I get 2 TV cameras, and I put one here at the MGH ER and one at Logan Airport, and I started to examine patients over this TV system? Now, you have to understand, I was a resident. He was my professor. I thought this was the stupidest idea I'd ever heard of in my life. But I had enough common sense to say, "Gee, Dr. Bird, that's a very interesting idea." By 1969, we had a fully functioning telemedicine system. And by the way, there's been a lot of debate about where the origin of the term telemedicine came from. To me, I don't understand why people are wondering. It was Dr. Bird. He looked at me and he said, "Well, look, we can't call this television medicine," because that's what we had, television cameras. He said, "Let's call it telemedicine." That's how it started, okay? And in 1969, we had a fully functioning telemedicine system in black and white. There was no color, but fascinatingly, the chair of pathology, Dr. Benjamin Castleman, the chair of dermatology, Dr. Tom Fitzpatrick, very quickly adapted to the grayscale. So they could tell whether something was erythematous or not simply by the intensity of the grayness. Every clinical chief of service started to use the system. We even had developed an electronic stethoscope. That seems commonplace today. It wasn't then. But there was one chief of service who said, this will never, ever work in my area. And who was that? That was Dr. Tom Dwyer, chair of psychiatry. Now, you might imagine my professor, and by the way, please understand, Ken Bird is the father of telemedicine. I'm not. I'm just a good student of his. Ken Bird came to Tom Dwyer and said, Tom, you're wrong. And Tom said, Ken, listen, this cold mechanistic technology will never ever be able to reproduce that special ambience between the psychiatrist and his or her patient in the room together. And Ken was a maverick. Ken got some additional dollars from the then general director of the hospital, Dr. John Knowles, who was equally a maverick. And they put another TV camera out at the Bedford VA hospital, where Tom Dwyer and his faculty used to travel every day to see the VA patients at the Bedford Roxbury VA hospital. 3 years later, Tom Dwyer and his entire faculty wrote a series of articles, they actually came out in 1973, on the incredible effectiveness of telepsychiatry. And what they found, and what he specifically found, was not only could he reproduce that special ambience, more importantly, he could manipulate the ambience. What he found was when he was dealing with a patient that he really wanted that patient to think about what he just said, he wanted him to chew on it and swallow it, he would begin to pan, remember, these were TV cameras, and I saw that in that ability in your presentation. He was able to pan the camera in, and this is what TV directors, movie directors tell you, well, of course, we create the emotions of a scene, not simply by the dialogue, not simply by the way the actors' faces appear, but the way we shoot the scene. And when Tom Dwyer wanted this patient to really think about what he just told him, he began to pan the camera in on his face. So as the patient is watching him, his face is getting bigger and bigger and bigger. To the patient, this was like coming from a much higher authority. And when he felt the patient wasn't ready to deal with the intensity of the moment, and he really wanted to sort of mitigate the intensity, he would sort of pan the camera back, and he became miniaturized in the patient's view. As you know, after teleradiology, probably the most frequent consultation today is telepsychiatry. You've all seen this, I'm sure. But I show it all the time because it's genius. It's pure genius, and it still tells us today what we need to do with our technology. The H, I'm sure you know, stands for Hugo. The yearly writing awards in science fiction, by the way, are called the Hugo Awards. This is Hugo Gernsback, who is the editor of this news magazine, and it still tells us everything we need to do with new technology. What is the technology being used for this science fiction telehome care technology? It was the most intuitive technology that existed in 1924. It was an entertainment device. Think about that. It was an entertainment device. It was a radio. TV hadn't been invented and commercialized until 1929. This is 1924, an intuitive technology that was incredibly simple to use. 2 knobs controlled everything. An on and off switch, which also controlled the volume, and a station changing knob. So you can go from your pediatrician to your dermatologist to your cardiologist just by changing a knob. And what could be less expensive than a radio? And we heard a lot this morning from speakers about patient engagement. Look at the young boy's 2 friends. They're amused, they're amazed by this. They're totally engaged in this. This was genius. But science fiction is science today. And the only difference between the two is time. Hugo Gernsback also thought about something we're still working on to perfect, and that's called haptics. The ability at the doctor at one end to virtually touch, feel the patient at the distant end. We started working on this when I was at the Medical College of Georgia and a senior research scientist at Georgia Tech with the bioengineering division. We started working on haptics. Our work was actually first highlighted in a very exceptional scientific journal called Playboy magazine. And I'll tell you that little vignette if we have time for questions at the end. But haptics is still being developed and will give us the ability for the surgeon who feels, I can't use telemedicine, I've got to be there and feel that abdomen, as if this device was really sensitive at all, or this device and a stethoscope. We'll get to that in a little bit. What's in a name? The previous panel said it all. And our speaker from MUSC really underlined it for us. The word telemedicine was introduced by my professor, and if he were alive today, the one thing I would say to him that he should never have done was to call it telemedicine. By the way, folks, I mean, we had telephones before we used those 2 cameras at the MGH. We never, when I told my patient, take 2 aspirin, I'll see you in the morning, I mean, I didn't call it telemedicine, it was medicine. We need to get rid of the term telemedicine. As a matter of fact, you don't really hear people talk about teleradiology anymore, it's radiology. Yet 70%, folks, of telemedicine is teleradiology. That's where the big volume is, but it's so commonplace to them now, they don't call it teleradiology. And that's what we need to do. This is just healthcare, and I'm going to show you in some subsequent slides why it's so important for us to understand that. So it really doesn't matter who does it, whether it's teledermatology or telepsychiatry. It doesn't matter what technology. Actually, it does. You have to use video. It doesn't matter where it's done, whether it's hospital to hospital or hospital to home or physician, primary care office to another doctor, specialist. It doesn't matter whether it's done in real time or store and forward. It's just medicine. Okay, there are really going to be 4 themes that I want to underline in this talk. And let me also apologize ahead of time because this is the same talk I gave in 1996 at the National ATA conference about the future of healthcare, and I'm just going to update the future for you in this. Now, don't laugh at the technology, but this was the most up-to-date technology in 1991. By the way, my first grant in telemedicine was under the National Science Foundation in 1973 to 1976 at the University of Miami. Don't give up, Tallahassee, don't give up. Actually, you better give up. Knowing the legislature of Florida. All right, so between 1973 and 1976, I tested telemedicine under a National Science Foundation grant at the University of Miami. I started the first nurse practitioner program in the state of Florida in 1972. 8 nurse practitioners, 2 of which were the dean and the associate dean of School of Nursing, and 6 ER nurses at Jackson Memorial Hospital. We took them through a 6-month course, certified them as nurse practitioners, used nurse practitioners with telemedicine as the experimental group versus board-certified internists physically on site. And what we found after 3 years of study was the nurse practitioners with telemedicine did as well as, and in some areas did better than, our board-certified internists who were physically there on site, as opposed to the nurse practitioners who were there using telemedicine for their consultations. That was 1976. And except for, true story, the Shah of Iran and President and Mrs. Marcos of the Philippines and the Secretary of Department of Corrections of the state of Florida, there was absolutely no other interest in telemedicine until 1991. As much as I tried. And during those 15 years, about the only one I could talk to about telemedicine was the reflection in my mirror. In 1991, the governor of Georgia, Zell Miller, asked me to set up a statewide telemedicine system in the state of Georgia. Why? We heard it from Tallahassee in the previous talk. Because he introduced himself initially to me as, Jay, I am the governor of 2 states. At which point I looked at him somewhat quizzically. And he said, yes, I'm the governor of Atlanta, and I'm the governor of the rest of Georgia. And he said, we have everything we need here in Atlanta, and we don't have everything we need in the rest of Georgia. And the most critical thing for him was the fact that most of the rural hospitals in Georgia were closing. They were going under because their bed census was drastically diminishing. And why was their bed census diminishing? Because the fundamental reality of every rural community in this country is that the medical staff of most rural hospitals are made up of general practitioners, an occasional internist, a general surgeon, many times a circuit-riding radiologist, at least in those days. And if you came in with a cardiological problem or a neurological problem, you were immediately transferred to an urban facility or an academic medical center. That's why the bed census was going down. But what the governor pointed out to me was something I had never, ever thought about, and that is the fact that when the rural hospital went under in a Georgia community, the entire socioeconomic fabric of that community went under within a 3 to 5 year period of time because the hospital was a major employer in town. This was an issue of jobs for the governor. So we developed a 59-site statewide telemedicine programs. First statewide telemedicine program in the United States, 1991. 3 academic medical centers connected to 9 comprehensive community hospitals. Each of those in turn connected to rural facilities, public schools, nursing homes, freestanding AHEC facilities. Cardiologist at the Medical College of Georgia, examining a patient at a hospital in Eastman, Georgia, 130 miles away. Of course, it wouldn't matter whether it's 13,000 miles away. It would matter if it's Mars, and if we have time, I can tell you about Mars. But here we have the patient where they live being taken care of by a specialist 130 miles away. And here is something I still, for some reason, I don't hear enough about one of the greatest strengths of telemedicine. We often focus in on the great advantage it is for the patient, but very few people talk about the great advantage it is to that primary care doc in that rural community. This is real-time continuing medical education. In fact, what we have found, we actually found this in the 1973 experiments that were funded by the National Science of Medicine, is that over a period of time, if you have an effective telemedicine system, the use of that telemedicine system to rural communities will go down for the best of reasons. Now that primary care physician knows what that mitral valve click is. Now that primary care physician knows what that maculopapular rash is and doesn't need the dermatologist. This is not only a benefit to the patient, it's a benefit to the provider. In 1993, it dawned on me, why are we waiting until the patient ends up in a rural hospital ER? Why aren't I beginning to do what Hugo Gernsback thought about as science fiction in 1924? And why don't I start to try and see patients in their home? So in 1993, we got a $1 million earmark from the federal government. They still did those things then. And we actually got a $1 million earmark from Tetrick, from Telemedicine Advanced Technology Center at Fort Detrick, Maryland. And we developed the first technology to go into the home. We called it the electronic house call. And interestingly enough, we got a call as we were developing this. We had talked about it a lot. We got a call from the local head of the cable company. It was then called Jones Intercable. They've been purchased since then. And we had coaxial cable. We didn't have fiber. I wanted this system to be totally interactive, but you couldn't do it. And they called and they said, well, we can do it. I said, how are you going to do that with coaxial cable? They said, oh, we can do that. We just add a reverse amplifier. We take it through an Ethernet bridge and you'll have interactivity. So we went to the hospital administrator and said, who are your 25 most revolving door patients? Who are your chronic disease patients who are constantly being readmitted to the hospital? And we got those patients. We set up this system with Jones Intercable, by the way, putting in the reverse amplifier and doing all of this free of charge. And I asked them, why would you do this? They said, Jay, listen, if this works, this is going to be like the movie channel. We're going to call this the health channel, and we're going to be able to charge the consumer $10 a month for the health channel. By the way, we can now do this on our internetable TVs. And we had a graphical interface on the TV screen. We had a picture of a stethoscope, and if I wanted to listen to that patient's heart and lung sounds, all the patient had to do, and we heard this morning, all they had to do was touch the graphical interface stethoscope picture that activated our stethoscope. We could listen to the patient's heart and lung sounds. But let me tell you the most important thing that we learned when putting in the system that we had never, ever thought about at the beginning. And I still don't hear enough about this. When we started, this Mrs. Jones, who keeps getting readmitted with status asthmaticus into our ER, intubated, sent to the intensive care unit, given maximum meds. Pulmonary function studies are close to normal when she's discharged. We see her at home 10 days later. We do a peak expiratory flow rate, and by the way, since I have video interaction, I can watch her do the peak expiratory flow rate, so I know her lips are pursed around the mouthpiece, and I know she's doing it correctly, and all of a sudden, I see an increase in her airway resistance. And then I realized, my God, why is she a revolving door patient? This is a woman with asthma who's sitting on a great big puffy chair. Okay, she's got thick rugs in her living room. Her husband is standing at the kitchen door watching this whole thing with a cigarette in his mouth, and she's giving us her history as she's petting her cat. For those non-immunologists in the room, we started to find our patients with hypertension who had been treating. When we took their blood pressure at home, the blood pressure was normal. What was great about this had nothing to do with the technology. Had everything to do with the recognition that the exam room needs to be where the patient lives, not where the doctor works. Under a NASA grant in either 96 or 98, we developed a healthcare kiosk. We now have robots. We now have beautiful kiosks. We now have our PCs. We now have our smartphones. And now with all of this technology, we want to make 100% sure that this never happens. Luckily, it hasn't. Okay. Now I've got to get serious. I'm going to say something that's going to disturb everybody. Telemedicine is potentially dangerous to your health. Because we're all enthusiasts. We all look at this technology as being fantastic. And we all forget the most important thing about what we're doing. The most important thing about telemedicine is not all the wonderful technology. It's not all the telecommunications infrastructure. The most important thing about telemedicine is the message. If I'm out of date, and by the way, I'm out of date. I'll always be out of date. I'm a professor of medicine at Johns Hopkins. Guess what? I'm out of date. I can't keep up. Not a single physician in this room can keep up to date. Well, if the message I'm sending out is wrong, what in the world is good about the technology? It's not. And I hope we're going to hear about this a lot more from a subsequent presenter. But I've got to get away from a single physician at the bedside to collective expertise. In 1969, I started doing AI at the MGH, prodded by another professor who was really known as the father of computers in medicine, Dr. Octo Barnett. But we didn't have the computer capability. In the mid-'80s, MIT became the center. They also quickly found out they didn't have the computer capability. Today, we've got the computer capability. And I can take all the physician and all the nurse knowledge that's in this room now with machine learning and AI and bring it to the single patient's bedside. And until we do that, I will always say at some point in time that telemedicine is dangerous to your health. I want to give you a reference if you think I'm exaggerating. May 2016, British Medical Journal, senior author from Johns Hopkins, the third most leading cause of death in the United States, medical errors. The third leading cause of death. Diabetes is the seventh. Medical errors is the third. We need to bring AI, and I hate the term artificial intelligence. It's not artificial at all. It's augmented intelligence. It's collective intelligence. And to my colleagues who think that I'm pointing a finger at them and trying to get rid of them, I'm not. You are all remain as critical when this is introduced as you are now, because each of our new observations at the bedside, each of our new observations at the research bench will be incorporated into the AI engine. This is a dynamic, real-time, living, breathing computer program that brings our collective expertise to that patient's bedside. Telemedicine has to be married to AI. I would point out, and I'll say this again in my next slide, that there's going to be another industry that's going to beat us to it. And as a matter of fact, please understand that telemedicine and AI in the medical space, don't any of you think that this is revolutionary. We are so far behind the times, it's amazing. Every other service industry figured out how to do this long before we did. Have any of you ever bought a book on Amazon? Amazon brings the shopping mall to us. Do any of you have Netflix? Netflix brings entertainment to us. Have any of you done online banking? All these service industries bring their services to us. Telemedicine and AI will bring these services to us in the healthcare space. And by the way, those industries are going to beat us to it, because I'm going to, at the end, talk to you about some of my recent conversations with Amazon and their 1492 unit. Do you know, have you heard about Amazon's 1492 unit? This is their strategic initiative, very hush-hush unit. Okay, so telemedicine, very important. AI, even more important. Continuous, unobtrusive monitoring, more important than the previous two. I hope none of you actually go in for a yearly physical exam. That's the most ridiculous thing in the world. And by the way, let me tell you, those of you in the room who have been told you're sick, you're lucky. Because the rest of you who've been told you're normal, you have not the slightest idea whether you're normal or not. And why would I say something that sounds as ridiculous as that? For the simple reason that laboratory tests that we all use, that we say, oh, you're fine. All of your tests came back in the normal range. How do we get normal ranges? We take millions of people and statistically grind them into normal ranges. There's only one thing wrong with that. It has nothing to do with you. And let me just give you 2 examples. My wife doesn't like this, but I always use her as an example. My wife's blood pressure, normal blood pressure is 90/60. Okay? Most women in this room, collectively, have a lower blood pressure than most men in this room. That's why you guys live longer than we do. So she'll go in next year for her ridiculous annual physical exam, and her blood pressure will be 95/65. And what do you think her internist tells her? Oh, Mrs. Sanders, your blood pressure is perfectly normal. And then the following year, it's 100/70. Then it's 110/75. Then it's 115/80. What do you think her internist has told her for the last 5 years? Oh, well, your blood pressure is perfectly normal because the normal range is 120/80 and below. That's the most ridiculous thing in the world. She's been hypertensive ever since she went above 90/60. Her shearing pressure within her aorta is denuding vascular endothelial cells. She's clumping platelets. She's developing atherosclerosis. But no, she's normal. Look, the blood pressure is below 120/80. If you came into my office today with a fasting blood glucose above 125, I would make an immediate diagnosis. You're diabetic. Guess what? I could have demonstrated that you were insulin resistant 10 to 13 years ago. Because your normal fasting glucose is 75, then the following year was 80, then it was 85, then it was 90, then it was 95. I had to wait till you got to this magic 125 to say you're diabetic. That's ridiculous. You were insulin resistant 10 years ago. Continuous monitoring is going to give us an identification of exactly when we started to get sick. I've told a number of automobile manufacturers, BMW in particular, that look, you need to develop a medical dashboard in the car. The minute you sit in the seat, folks, I've got your weight, whether you like it or not. The minute you put your hands on the steering wheel, I've got your pulse, your rhythm strip, I've got your RR variability. And the minute you take your seatbelt and plug it in, I've got your respiratory rate, your respiratory volume, and with some neat signaling processing, I've got your mean arterial blood pressure. Why don't I have a medical dashboard in my car? And now when I get angry at this guy next to me who's just trying to cut me off, I can watch my PVCs starting. Mid-1990s. This shirt, called the Viva Metric shirt, was developed. It was paid for by DOD. It was used up at Natick, Mass. Great shirt, measures 42 physiological parameters wirelessly. Great technology, bad business people. They went out of business. But great technology. Watches. Tattoo, developed by MIT. And some work we did with NASA in the mid-90s. You shine the appropriate polarized light on that, and will give me your blood electrolytes. Hopefully 10 years from now, when you walk into the doctor's office, if there's a nurse there coming at you with a syringe and needle to take some blood, run. Go to another doctor. Because this is the technology of tomorrow. Everybody heard of the body area network? The body area network The FCC knows about it. The FCC has developed spectrum for your body area network where all your wearable, embedded, and circulating sensors. One of the things I do is I head up the Scientific and Medical Advisory Committee for National Science Foundation Nanosystem Center, where we're developing self-powered sensors that'll either be worn, be embedded, or they'll be less than 7 microns and they'll be injected, circulating around. And you will be constantly monitored and totally unobtrusively monitored. And in the cloud will be your vital signs, yours individually. So if you have a blood pressure of 90/60, when you go up to 100/70, an alarm will go off. And to prove to you, everybody knows what this is, right? How many Trekkies? Aren't there any Trekkies in the room? Yeah, it's a tricorder. This is 1.0 tricorder. And by the way, I'd like to announce, as of yesterday, late yesterday, the FDA approved a technology from a company called Butterfly that is an ultrasound on a chip going into a smartphone. By the way, do you know who a year before he died got the patent to collect medical physiological data from body-worn sensors into a smartphone? Steve Jobs. Brilliant, except for himself. He'd be alive today if he listened to his physicians. This device is my electronic black bag. This device is your exam room. Do you remember about 2 years ago, there was a big business announcement between Apple and IBM? Guess what's going into your smartphone, folks? Watson. And the sensors will communicate by Bluetooth into the smartphone. And if AI is not in your smartphone, it'll be in the cloud. That's my collective intelligence. That's my AI in the cloud with my sensors, knowing exactly when I became insulin resistant. Exactly when my blood pressure became hypertensive for me. Today, with this device, without the Butterfly ultrasound on a chip, I've got a microscope, I've got a stethoscope, thumb and index finger, I've got an EKG. I have everything I need with this, and with the photonics, soon I'll get all blood electrolytes. Final, the issue of who will be the primary care physician of tomorrow. Folks, it's us. It's you and I. The big problem that we have today in our healthcare delivery system, as much as we'd like to point a finger at the government, at our insurance company, at our provider, we need to begin to point the finger in the direction it always should have been pointed, right here. Because I can know everything about myself, that I'm overweight, that I don't exercise, that I smoke, and if I still do all of these things that lead to this, doesn't matter how good all of our technology is, it's not going to work. But guess what? I'm sure you all heard who won the Nobel Prize in economics, Richard Thaler, who wrote a book, Nudge, with his co-author, Cass Sunstein, both University of Chicago professors of law. Many of you read Nudge? You need to read it. Good for you. You need to read Nudge. It talks about behavioral economics. So let me tell you what I was talking to Amazon about. Behavioral economics basically encourages you to do the right thing from an economic standpoint. So one of the things I called them about was Alexa. You all know Alexa. And you all know the fact that Amazon recently bought Whole Foods. And I suggested to them that with Alexa and AI, integrating the patient's electronic medical record into that, if the patient now orders food from Whole Foods and they're diabetic, and the food that they're ordering is inappropriate for their diabetes, Alexa would say, look, we would suggest you choose this food instead of the food you ordered. And by the way, if you do order the right food, we'll charge you less for that. Think about the behavioral economics of that. Think about who then becomes the physician in that setting. It's that behavioral economics that are going to change patients' behavior. I'm not sure that's going to do it. And I just want to remind you in ending that there are certain human instincts that are going to be very, very difficult to change, although I think the economics will. I want you to know that resistance to change has been more of a problem today with my colleagues than it really has been with the public. Because look at the public. Every single one of you has a smartphone in your pocket. Every single one of you, I'll bet, does. Please take a moment to read this. I know I'm just slightly over time, but it's important for you to read this. This appeared in the London Times in 1834, in which the Royal Society of Medicine, who are the authors of this quote, the most prestigious medical body in England at the time, said this new technology will never ever work and comes between the doctor and the patient. The first stethoscope. And the best way to end this is to leave you with this quote from Ralph Waldo Emerson. Thank you very much.